Okay, welcome, folks. As people are logging in, we're going to get started. Hope everyone enjoyed celebrating and commemorating and reflecting on Juneteenth yesterday. And we want to thank folks who have been following along with this webinar series for joining us back again to talk about a really important aspect of medical legal partnership work, and that is working with patients who have opioid use disorder or substance use disorder, and how partnering with legal aid can move OUD SUD care upstream. So welcome back. I'm Bethany Hamilton with the National Center for Medical Legal Partnership. You're joining us on our Health Center MLP PIP webinar series, where we help folks better understand how they can plan, implement, and then carry out best practices in MLP. As you can see on the screen, you're joining us on June 20th, 2024 at 1 p.m. Eastern time, and we run for about 90 minutes today. Also, you can see that we partner with Texas A&M Health Institute for Healthcare Access on this webinar series. Let's go to the next slide. So as has typically been the case, you are joining this webinar on mute. However, this is a really interactive webinar series. We purposely designed it to be small so that we can actually unmute folks. But we encourage folks who are maybe less inclined to speak using the unmute function to just go ahead and submit questions using the Q&A pane or the chat. Reha Manikanasamy from the National Center team and I will be in the chat along with our guest speakers, and we will have a Q&A section or segment of today's presentation dedicated. There will be ample time, so submit your questions, don't hold them. We don't want you to forget them. Just start submitting them as soon as they come to mind. If you need transcripts to show up or caption, click on the More button on Zoom. That way you can get the option to activate captions by clicking on Live Transcript and showing subtitle. And for those who are wondering, yes, this webinar today and the entire series will be recorded and shared along with the slide deck on the medicallegalpartnership.org website under the resources section. Also, I would encourage everyone to sign up for our biweekly newsletter, the MLP Update, so that you can see when we share not just the recordings, but also the next webinar that we have available in the series or other resources that come about. Reha, let's go to the next slide, please. So very quickly, this is the icon that folks will see on the screen. If you've been following along, you'll recognize this. This is how we will indicate that at certain points, you may raise your hand to unmute. We will encourage folks during the Q&A to do exactly that, as you have been throughout this webinar series. That way our guest speakers can really interact with you, make sure they understand the question you might be posing about the important work that they're carrying out on behalf of, in this case, the city of brotherly love, or the city of Philadelphia. So look out for this icon, as well as some additional polling options that we will have throughout today's webinar. Next slide. All right, so I know folks have seen this alphabet soup before, but on this slide, you'll see that we added some more ingredients to the soup. So by way of very quick background, to ensure that everyone's on the same page here and level set, MLP is medical legal partnership. If we are talking about health centers in particular, you may hear us say community health centers or CHCs, FQHCs, specific designation related to the health centers, that's federally qualified health centers. Those programs, the health center program is administered by HRSA, the federal agency that is spelled out as Health Resources and Services Administration. And many of them partner with legal aid organizations that are funded by a different federal agency, LSC, the Legal Services Corporation. For today's webinar in particular, our guest speakers added some additional ingredients that might be helpful. You will hear terminology like OUD or SUD, and that's opioid use disorder or substance use disorder. You may also hear folks say MAT or MAT services, and that stands for medication assisted treatment. So look out for this. We'll reiterate some of this throughout the more substantive presentation from our guest speakers, but we wanted to make sure people knew what we were referring to in this upgraded alphabet soup, if you will. Next slide, please. This is a series that has been funded by HRSA, the Health Resources and Services Administration. The National Center is in its 10th year of funding to provide training and technical assistance and resources to medical legal partnerships, especially those specifically based in the health center world or space. But we do find that the content, as you all will is really helpful across different types of settings. I just want to note that what we're presenting on here today, NTMLP and our guest speakers, represents our views and not necessarily the official views or of HRSA or HHS. Let's go to the next slide. All right, so we're following along through a series that walks through our Health Center MLP toolkit. As you can see in the chat, so go ahead and download the toolkit at that link that Reha shared in the chat to the toolkit. Use it. Also, just noting again, this is an interactive webinar series, so we're engaging in active learning. Use the Q&A, use the chat. When we get to the broad Q&A at the end, we'll encourage people to unmute and talk to our guest speakers today. All right, next slide. Let's get ready to engage. So you all know the drill here. We usually warm up with a poll just to get to know who's in the audience. Reha, let's go ahead and launch the poll. All right, so question number one is, again, what type of organization are you from in today's audience? Are you from healthcare, legal services, academia, or other? Does your organization have a medical legal partnership or MLP? Let us know. Perhaps you don't know, and that's okay. And then as it pertains to today's particular topic, we'd love to know, does your MLP currently involve a partnership with a behavioral health or mental health care provider or organization? And finally, the last question is, does your MLP specifically work with patients recovering from substance or opioid use disorder? So let us know. Try to keep it simple today with yes, no, or not yet, or I don't know type questions. We almost have full participation, so let's just get in a few more seconds for the final responses to come in. Again, the questions very quickly are, what type of organization are you from? Does your organization have an MLP? Does your MLP involve a partnership with a behavioral or mental health care provider? And then finally, does your MLP specifically work with patients recovering from substance or opioid use disorder? All right, let's go ahead and close out the poll right hot and see the results. So a lot of folks are in legal services, also from healthcare and academia joining us. The people who answered other, take a moment to type in the chat box where you're from. We'd love to know where you are representing. Also, everyone's welcome to let us know in the chat where you're from. We have a really pretty even split actually of folks from MLP with MLPs and without MLPs, and then folks who are not yet sure. So hopefully for those who aren't yet sure if you have an MLP, we can help you ask the right questions to figure some of that out. Really curious to know where you might be from, so we can help guide you in terms of who to ask if you do have an MLP versus legal services referral network. You can also see on the screen that several of you are actually partnering with a behavioral mental health services provider. So we hope the content today is particularly helpful in terms of focusing your work on patients with SUD or OUD. And then finally, same thing for those who are not yet partnering with those types of providers, but then you can see a similar split for people who are focusing their work. About 46% of you are working with patients with SUD or OUD. Some are not, the other half are not, and then some folks have said, no, they are not yet working with that patient population. All right, so we're going to pull down the poll and move things along so that you all will get to hear from today's guest speakers. So you'll see if you're following along with the toolkit that we are in the using MLP to move upstream and address emerging issues, in this case, substance use disorder or opioid use disorder. This is in part 4 of the Health Center MLP toolkit, where we talk about moving upstream from patients to policy work. Let's go to the next slide. Before we move into today's learning objectives, I just want to put in a plug to highlight that we're going to have next week the closeout to this webinar series. And so take a moment now, we'll pull this back up at the end to make sure people know about this MLP town hall. So every summer thus far at the National Center, we really provided space during the month of June so that we could have a more interactive sort of forum discussion for people to be able to talk about their MLP emerging issues or implementation challenges. And so we're using this particular webinar series to frame the conversation. And so we're inviting folks to join us, and also feel free to spread the word so that we can have a really robust conversation about MLP planning, implementation, and practice. totally open forum. We really want to hear about what you're working on and what you need in terms of tools and resources to help advance your efforts and initiatives. So join us next week. Register now. Now the next slide. Thanks, Reha. All right, so now the next slide talks about today's learning objectives. Number one, we're hoping that after today you better understand some lessons learned from integrating legal advocates and advocating, and expanding to address a new demographic and their needs. We're also hoping that we can help you examine some key factors for effectively serving patients in opioid use disorder or medication-assisted treatment programs. And then we're also hoping that we can help you interpret evaluation findings. So we know this is a high demand topic, evaluation. So we're hoping we can better assist people in terms of interpreting and evaluation findings on efficacy and economic impact of the medical legal partnership approach or model, in this case presented by Philadelphia Legal Assistance. Speaking of, let me tell you who's joining us here today. Let's go to the next slide. This is, of course, the faculty group I'm moderating for today, but you can see our partners. We've been working with Keegan Warren and Jay Sicklick. And then on the next slide, our guest speakers are Margaret Robinson, supervising attorney of the Medical Legal Community Partnership at Philadelphia Legal Assistance, James Tidrington, supervising attorney of the Medical Legal Community Partnership at Philadelphia Legal Assistance, and then Erin Davison, who is founder and principal consultant of Davison Strategic Solutions. She performed the evaluation and is a researcher who will be presenting the evaluation findings at the tail end of today's presentation. Next slide. So welcome, 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 and thank you to Philadelphia Legal Assistance team and Erin Davison. All right, Reha is online today, managing our tech, but she's our team's data scientist. So if folks need assistance from the National Center related to the resources that are prepared as a result of this webinar series or anything else related thereto, reach out to her at ncmlp@gwu.edu. Next slide. And really quick, just to make sure people know what else we covered. If you joined us last week, you will have heard from Kate Marple, who helped us better understand how to ditch the elevator pitch. If you'll recall, she walked through some lessons on how to build effective messaging for different MLP audiences. So if you joined us, you will have hopefully better understood what inspires people to take action, how to identify or the development of strategic messaging for any audience, and then really how to develop MLP messages that focus on outcomes rather than just processes, with a special focus on what we know folks have been asking us about, how to talk to healthcare organizations and funders about MLP work. All right, with that, I am now going to kick things over to the Philadelphia Legal Assistance team. I understand that Margaret's Wi-Fi is having trouble, so we're going to wait for her to come back on in a moment. And I just want to ask our second speaker, James Tidrington, if we can kick things off with starting with James first as we wait for Margaret.
Yeah, I'm perfectly. Yeah, I can cover Margaret until she comes back.
Much, James.
Absolutely.
All right, thank you.
And we'll just continue with the same slide order as well.
All right, thanks, James. All yours.
So yeah, so thank you everyone for joining us today. We're very excited to talk to you today and hopefully get some interaction. So today we're going to just be talking about our medical legal partnership in general, and then get into a little bit of the work that we do with MAT patients or patients in recovery from opioid use disorder. And then Erin did a great research project for us to measure the efficacy or the efficiency of our project and sort of the economic benefits that that our work does for the entire community of Philadelphia. So next slide. So again, we have a medical legal community partnership. We added sort of the C of community in our MLP to really highlight the fact of integrating with the community is a real important goal for our unit here at Philadelphia Legal Assistance. And I see Margaret joined us back. Margaret, I just started. I don't know. Do you want to take it back?
Yes, I'm so sorry about that. Just at the perfectly wrong moment, the Wi-Fi went out. But thank you so much, James, for covering for me. I think as James was saying, just a brief overview of our session. We're very happy to be here to present about our project. We're going to do a little bit of a discussion about our history of our project, what we figured out, and what strategies we've been able to develop in our history so that have helped us work in our work with patients in recovery from opioid use disorder. Then James is going to talk more specifically about our OUD and medication-assisted treatment work. And then Erin is going to talk more about her research into calculating return on investment for our model. Next slide, please. So just to give you a little bit of a background of where we started, where we are today in terms of the medical legal community partnership. We have a staff of 20 legal advocates, and we operate at 17 different clinics throughout the city of Philadelphia. We're currently partnered with a number of FQHCs, hospitals, MAT programs, and other sort of community clinics. So we work with the Philadelphia Department of Health. We work with clinics run by Delaware Valley Community Health, Esperanza Health Center. We have 2 hospital practices at Einstein Medical Center and Temple University Hospital, as well as Fair Hill Community Practice. And we also have a partnership with a managed care organization, Jefferson Health Plans. Next slide, please. So I just wanted to show you, so you can have a sense of the geographical reach of our project and the sort of variety of the different locations. So you are seeing a map of our beautiful city of Philadelphia. The different colors on the map represent different clinics, healthcare sites that we partner with. So for the orange, you'll see that's the Delaware Valley Community Health with 2 sites. We have 3 sites working through Temple and Fair Hill Community Practice. With Philadelphia Department of Public Health, they have 8 ambulatory health centers, which have a broad geographical range throughout the city. So with the blue dots, you'll see that. We work with Esperanza Health Center at 3 locations. One of the most relevant to this topic is our Kensington location of Esperanza Health Center, where they operate their medication-assisted treatment program. We work at Einstein Medical Center, and then we also work remotely at an additional 5 sites through our Jefferson Health Plans portal project, which I'll describe more in a moment. Next slide. To talk more about our history with the Philadelphia Department of Public Health, because that is one of our largest partners. We really started this project almost completely on a volunteer basis. We had an attorney who came on additionally as a volunteer who had a lot of experience in the public benefits world back in 2013. And she was able to pull together a team of volunteer law students that figured out how to make it work at Health Center 3 in West Philadelphia, and really began this project and lay the groundwork for our success in years to come. So the following year, we expanded to another health center with Philadelphia Department of Health, Health Center 4, still largely a volunteer project. In 2020, we were able to get funding directly from the city's Department of Public Health to expand to Health Center 6 and Health Center 10. And then in 2023, we expanded to all 8 ambulatory health centers in the city. So we're now any patient of a Philadelphia Department of Public Health health center has access to legal services through our projects. Next slide. And so in our working with PDPH, I wanted to highlight some of the strategies and things that we've learned that have been really helpful in building our project, and ways that we figured out how to be successful in carrying out our goal, which is to address the legal needs of patients. At these clinics, we see patients who, we see a large number of uninsured patients, and patients who are recent immigrants often are patients at these clinics. And we've also found that these health centers, in many cases, can be strong community hubs. Patients there see it not only as a place to get medical care, but also as a place to get resources, other types of social services or information. They may come in with questions if they have, processes or agencies or organizations that they're trying to get access to and understand. They may see the clinic as a place that's responsive to their needs. So we have really been trying to take advantage of that role that these clinics can play, and all of the groundwork that the very dedicated providers have laid towards showing their patients that this is a place that they're welcome, that can be a resource, to try to add that legal services element and bring that to folks who may face other barriers to accessing legal services. One of the strategies that we've really employed throughout our time with Philadelphia Department of Public Health is flexibility. We found that having a physical presence on site has been really key to the success of our program, to making sure we're there to meet patient needs and to ensure that they know about us, that they're getting to us. And at times we've had to be flexible about our workspace, or kind of work around the many systems and protocols and processes of the PDPH system. But we found that that's really paid off in terms of the success of our project and being able to serve our patients. Another aspect of flexibility that we figured out in our project that has been really helpful for us is being open to taking on members of the writer staff or clinical and non-clinical staff members who have legal issues of their own. We found that many people may come to us with questions, needing a little bit of legal advice about a situation they're dealing with, and that providing that information to them was a great way to establish trust and also sort of give them a picture of what we do. And then that person is going to be much more likely to refer a patient to us in the future. In addition, many of the staff members or their family members may be LSC eligible, so they really were someone that we could take on as a client for our organization, but also have a personal connection. Next slide. Another thing that that's been really interesting to learn from this partnership is learning how relationship building impacts the success of the project. It's a really interesting question to me to try to understand what drives referrals, why there may be more referrals at one location than another location. We know there is a need out there among all of the patients that we see. We know there is a need for legal services. And yet some patients make it to us and some patients don't make it to us. So we've really tried to take a close look at what the reason is behind that. In some cases, it really can be sort of protocols. If staff are doing screening every patient, what they do with those screenings, what the processes are in place, places where everyone understands sort of what they're supposed to do if they have a patient who answers yes on a social determinants of health screener. But we've also found that relationships with staff, both clinical and non-clinical staff, can be equally important in generating referrals. It may be a question of a staff member's having a conversation with their patient, and something that the patient says figures in their mind, oh, this should be a good legal referral. Or, I know our MLCP advocate can help with this. And that kind of personal relationship of just having us, form topmost in someone's mind can be also a very effective way to encourage referrals. And this is not just limited to, doctors and nurse practitioners. We found that in many of our locations, we get a high number of referrals from staff members like security guards or interpreters. These are folks who may be in a better position to sort of be having a conversation with patients as they're coming in and waiting, and the patient may be more likely to disclose a legal issue to them. So we really see the entire staff as a resource of possibly receiving referrals. Another strategy we've developed is to really maximize the face time of the legal advocate. If we have an opportunity to present something at a meeting, we will always take it. If a doctor asks us a question, we will reinforce in our response that that we're happy to get referrals. If they see this in the future, please send people to us. We also see, we may have a situation where we're just providing not necessarily legal advice, but just something that could be of interest to doctors. I was working with a provider who said he'd always wondered why some kids with asthma are eligible for child SSI and some kids aren't. And we were able to do just a quick presentation on child SSI eligibility. But that kind of FaceTime, that kind of interaction is really helpful for establishing a reminder that the next time he sees a kid who may be eligible for child SSI, we're available. And also patient word of mouth. We know our patients communicate about where resources are. So we're always happy to have one patient send another patient to speak to us. I'll also add that my colleague James is famously known as the donut man for bringing donuts in to meet with staff, just having that personal interaction, getting to know staff by name. All of those things we found have been really helpful for increasing referrals. And then finally, we were able to, after working for 10 years, we were able to get access to the electronic health records at PDPH, which has really helped with integration. It's really streamlined communication we have with the staff. It has been extremely useful in terms of streamlining referrals. There are a number of legal and ethical issues that we have to keep in mind. It's definitely something that needs to be done with consideration. But we found it very beneficial. And in general, I would say one strategy that we've employed is to really understand at a given healthcare provider, how are staff communicating? Is it EHR? Is it Teams? Is it email? Knowing where those conversations are taking place and trying to get in there has been really helpful for us. Next slide. And so just to summarize with our work in PDPH, the most common legal issues we've seen there, because we see a lot of uninsured patients and a lot of patients with different immigration statuses, is the intersection of health insurance eligibility and immigration status. We see a great deal of public benefits and income support cases. We do see a high need especially among older patient populations for personal planning documents, advanced directives, powers of attorney, wills. And we do typically see a high number of utilities cases in those clinics. Next slide. So next in our sort of MLCP history, I want to turn to the beginning of our work with the opioid use disorder population, MAT population. And that came through with a 2018 HRSA grant to provide services where we partnered with Esperanza Health Center and Delaware Valley Community Health, specifically at their Girard Medical Center MAT program. From 2018 to the present, we received ongoing funding from partners and private foundations. And in 2023, we received funding from the Pennsylvania Commission on Crime and Delinquency to expand our services at those locations, which is the source of our current funding for that project. We do have a number of things that we've learned, strategies we've implemented about our MAT work. And I promised James I wouldn't spoil his section. So all of those are going to be in the next section of the presentation. Next slide. So another important partner in our work has been through Jefferson Health Plans. In 2020, we started a partnership with Maria de los Santos Health Center, which is part of Delaware Valley Community Health, to serve patients who have Health Partners Medicaid. So this was funding available for patients who are part of the community-based care management program that they were able to take from Jefferson Health Plans, the managed care organization, and use for our advocates to address social determinants of health. In 2021, we expanded that project to include adult and pediatric clinics at Einstein Medical Center. In 2022, we started at Temple Pediatrics and Fair Hill Community Practice. And we also started a portal project where community-based care management staff could refer patients directly to us, where we have staff working remotely, not working necessarily in the on-site in the clinic, but where the CBCM staff are able to make legal services referrals directly to us from 5 different locations. Next slide. So working with our JHP partnership has really helped us get a clearer understanding of the role of an MCO in addressing social determinants of health. We've had some great partnership on their side from folks who are really concerned about both health outcomes and just overall well-being of their patients. We're very lucky to be working with them in that they have a strong team of people working with patient care. And so as we've understood those teams, we've really been able to all work collaboratively and kind of maximize our individual areas of expertise to benefit patients. So we worked with nurse navigators, social workers, behavioral health providers, and community health workers who have been part of the community-based care management team. And we've had some great collaborations where, I'll be helping someone with a legal issue and the patient will mention to me that they've been having some behavioral health concerns. And I can easily refer them to a behavioral health provider or social worker, and vice versa. Somebody may be working with a patient about medication and understand that their electricity was turned off and they can't put their medication in a fridge, and they can easily send them over to me to address the utility issue. So that's really been a really fruitful partnership with those teams. And we've also been able to work on sharing outcomes of our work and client data. Our sort of research dream would be to be able to, sort of understand more fully the impact of addressing SDOH on health outcomes for our patients. So maybe someday we'll be able to partner in that way. But that's been another resource that we've had from this partnership. In terms of some of the challenges of this partnership, we do have patients who, where we'll be in a particular location that serves patients with a number of insurance types. And we are limited to providing services to patients with one type of insurance. The ways that we worked around that are to some extent work with providers to make sure they're referring patients with the right insurance to us. But on the other hand, we never want to sort of close the door to any patient. So if anyone gets referred to us that doesn't happen to have the kind of insurance that we're getting our funding from, we would always work with them, sit down with them, find out what's going on, and make sure that we can refer them to another legal services provider in the city. Next slide. So some of the things that we've learned from our JHP partnership, we have definitely expanded our understanding of the specialized legal issues that arise with pediatrics practices, and including some particular legal issues that tend to come up: special education, child custody, asthma, lead, and also the particular ethical issues that come up in representing children, particularly where the parent is coming to us for assistance, but we also have a relationship with the child via the clinic. In addition, we have worked very hard to develop our portal project. So we do have the benefit there of working with community-based care management teams at those locations. But that project does present some challenges from not being able to work on site, missing out on that integration factor. So it's a balancing act between being able to serve a larger number of clinics, but on the other hand, not having necessarily that face time with the staff. Next slide. So some of the most common legal issues we see, I'm focusing for our Jefferson Health plans on pediatrics. We see many issues involving child custody. These tend to come up both in the area of authorization for treatment. For example, we may have a caregiver who's been taking care of a child for years, possibly the child's entire life. But then if the child needs specialized medical care, this person doesn't have the appropriate custody order to be able to consent to that. So that's where we can step in and make sure the child's able to get the care by getting whatever custody order is needed. We've also noticed that pediatrics offices can be a location where there is a high likelihood of custody disputes. If the parents are in dispute, they both may show up for the doctor's appointment. So we've been able to step in there on sort of being able to be easily available when those kinds of disputes arise. We've also seen a lot of issues with housing conditions, where there may be mold, lead, or pests in the home that are causing health issues for children who are more susceptible to them. We've had great examples of being able to work with a provider who will say, not just, clean up the mold, write a letter to the landlord saying clean up the mold, but to say specifically rip out this carpet and here's exactly what you need to do in the house. So it's great to have that partnership when dealing with these issues. We do get a lot of referrals for special education. That's been another opportunity to kind of work really closely with providers and their expertise about child development, and to bring into that our understanding of the rights that parents and children have to appropriate education, as well as school bullying. And once again, we see a fair number of cases with utilities. So I think we can go to the next slide. I think that will wrap up my presentation, and I will turn it over to my esteemed colleague, James.
Thanks, Margaret. Yeah, so we're just gonna kind of reset a little bit and do a poll here. And I apologize, maybe the wording is a little confusing, but question is, how many legal needs does an MAT patient have compared to a non-MAT patient? And this came when we started, as Margaret pointed out, we started our MAT work in our MLP in 2018 through a HRSA funding grant that we received. And so prior to going into Esperanza Health Center and DVCH over at Girard Medical Center, we did a needs assessment to determine, what the needs were exactly at these particular sites to figure out staffing um, and availability, what days we needed to be there. And then we had also done a needs assessment, needs-based assessment on our other health center sites. And so this is kind of an informal statistic here that we did ourselves, and this is kind of what we came to. And so again, so the answers here: for every one legal issue a non-MAT patient has, an MAT patient has half of that legal issue, so 50% less than the legal issues that a non-MAT patient has, or is it a 1-to-1 ratio? A 1.5 to a 1 to 1.5 ratio, a 1-to 2 ratio, or for every one legal issue a non-MAT patient has, MAT patient has 2.5 legal issues. And so I'll just give everyone maybe 5 or 10 seconds to just think about that. And I think that's good enough. So the answer is actually E, that we found. For every one legal issue that a non-MAT patient has, an MAT patient has about 2.5. I think it was 2.7 from if my memory serves, which just kind of makes sense if you think about it. Patients or people in people with diagnosis of opioid use disorders or in active recovery, they're kind of coming back to things, and they have likely a lot of legal entanglements trying to get set back up. Maybe need help with welfare benefits, getting their IDs, family law issues, kind of everything and anything really. And so if you just kind of think about that, I think it just naturally makes sense that MAT patients or patients in recovery generally have a lot more legal entanglements than need. And then I think also tied with that is just lack of access to resources, which I'll get into a little bit more for MAT patients, or again, individuals who are in active recovery. All right, if we go to the next slide. So again, sort of jumping off again, sort of that poll question. This, I think, our MLP has been in existence, about 12 years now, 11 years. And the work that we do is really beneficial to every single client that we work with. But I found, particularly working with patients in recovery from opioid use disorder, you're hitting a patient population or community that normally, again, doesn't have access to free legal aid or just resources in general. And so the impact that we're making for these individuals' lives, I think, are greatly magnified just by the nature of what's going on in their lives. Because recovery from opioid use disorder, as I'm sure everyone is aware of, is very a difficult process. Lots of stressors, lots of barriers, and that's where the MLP can kind of come in, as all MLPs do, to come in to remove those stressors, to remove those barriers to access to legal justice. And then here, particularly with those patients who are in MAT or medication-assisted treatment, and instead of having to figure out, my food stamps were cut, or my social, my SSI claim got denied for the third time, that's something that we could take on and help them so that they could really focus their attention and their time on their recovery process and know that they have some support in the legal needs. And so that's kind of where we come. And this talks about sort of that the MLCP treats the whole person. Because a lot of our the two MAT clinics that we're at, it's a very multidisciplinary approach where we're working with behavioral health counselors, we're working with the primary care provider, social workers, recovery specialists, and alike. So it's really this MLP, coming into an MAT setting, I think is just, again, another, it's a valuable part of that MAT treatment, I believe. Let's go to the next slide. So I'm sure everyone is aware of the opioid use problem here in the United States. We're just kind of to set the numbers. I recently updated these numbers, and sadly, the numbers never are always surprising to me, and it's always sad to kind of get an update every year to see sort of how things are shaping out in this world. So in 2021, I pulled numbers from the National Institute of Drug Abuse. And so in 2021, 2.5 million Americans 18 years or older had been diagnosed with an opioid use disorder. In 2022, the NIDA found that over 81,000 people died in the United States from opioid overdose. And again, from NIDA in 2021, about 500,000 adult Americans are receiving MAT treatment, which it's about 22, if you do the math, it's about 22% of diagnosed OUD users are, so about a quarter, less than a quarter, are actually receiving treatment for their diagnosed opioid use disorder issue. And then here in Philadelphia, took some more numbers in 2020. There's been found to be over 76,000 Philadelphians who have been diagnosed with opioid use disorder. And the city of Philadelphia, or Philadelphia Department of Public Health, they did a study and found in 2022 that 1,413 Philadelphians died from an opioid overdose here, again in Philadelphia. So again, a very huge problem in our country and also here in Philadelphia. Unfortunately, we have a bit of drug tourist markets, particularly in some of our neighborhoods and communities here in Philadelphia. So it's really prevalent, and just putting the numbers out there just kind of set that picture here. So if we go to the next slide. And then I'd be remiss not to mention fentanyl, of course. People are probably very familiar with fentanyl, even more serious substance that's kind of been more prevalent out there in street drugs. And so and again, I think I took this number from Philadelphia Department of Public Health. So in 2010, they found that fentanyl was detected in less than 10% of overdose deaths, while in 2020, fentanyl was detected in over 81% of overdose deaths. So it's, fentanyl is a very dangerous drug and can lead to more and more overdoses. And it's just that also, buying street drugs, it's that unknown. You're not sure what you're actually purchasing or ingesting or putting into your body. So it's also, it's getting more and more dangerous out there, unfortunately. And then in the neighborhoods that we particularly serve in for MAT patients, for some of the health center sites, people might be familiar with the Kensington neighborhood or the zip code 19134. And there's a study there that unfortunately showed that, unfortunately, a minority has been hit the hardest with overdose deaths. And so in 2018 to 2020, overdose deaths increased 80% for non-Hispanic Black individuals, while 43% among Hispanic individuals. Again, I think just showing that, it's really hitting the communities that, again, have been historically underrepresented or under-resourced. So there's a lot of need there, certainly. And then again, in 2020, the highest number of opioid overdoses were in the 19134 zip code, which again is in the Kensington neighborhood. And if we go to the next slide, I think I have a map. Yeah. So here's a map which kind of shows, so this is our county of Philadelphia here with the zip codes attached to it. And the previous slide I was talking about 19134. So you can see that's that unfortunate dark shade of blue. And the different shades of blue there kind of just shows the density of number of overdose deaths within that area of Philadelphia. And if we go to the next slide, this again is just kind of bring back where we're located situationally in Philadelphia. And Reha, if you don't mind going back, so I just want to compare and contrast for people. Again, if we go back to the previous slide, again, you can kind of get a sense of where the opioid epidemic is hitting Philadelphia the hardest here. And if you go back to the next slide, Reha, then again you can kind of see where our locations are important. We're hitting a community I think it's just the general idea of the MLP, but also here I think is a perfect example where many people, we have an office downtown, and for variety of reasons, many people cannot access our downtown office via phone or in person or online or whatever. And so obviously the MLP, it's all about bringing those services to the community by embedding those legal services within the existing healthcare facilities at health centers, hospital settings, et cetera. And so, here we're going out into those communities, again, those communities that have been hit particularly hard with opioid use epidemic. And so just to sort of highlight that point potentially. All right, if we go to the next slide. So I'll do a sort of a brief sort of discussion. I did see the poll. I think a lot of people already, maybe it looked like 50-50 attendees had an MLP in an MAT setting or opioid use setting or a drug and alcohol setting. So people may be familiar with this, and I do apologize ahead of time as I am not a doctor, but so I'll try my best to sort of go over this sort of more of a lay person's explanation of sort of what medication-assisted treatment is. So there's generally three medicines that I'm aware of most familiar with is Suboxone, and then methadone, and then naltrexone, used to treat opioid use disorder. People might be most familiar with methadone. I think that has the most stigma of a drug, MAT medicine, because it does, I think at a visual, if you look at someone maybe that's on methadone, it does appear that maybe they still have some impairments or something along those sense. And then Suboxone is kind of that middle ground where it's actually blocking the receptors for those opioids, so that you can when you're taking the drug, that you can't actually receive those highs or those lows. And then naltrexone is kind of the lower end of the sort of these three medicines, and I think naltrexone is a once a month injection. Again, if my memory serves. And with MAT, unfortunately, there's a huge stigma. Many times I've had to go to court and talk to judges or just other, probation officers. And talk to them about it's all case relative. It's about how the individual responds, their level of use. And so MAT medications, they're safe. They're OUD, opioid use disorder. It's a diagnosis. It's in the DSM. So this is how you treat individuals who have OUD, and it's safe to use. It can be used for months or years or even, for many, many years with close consultation of a doctor. And this is the part where I have to sometimes come in and start educating, again, judges or more probation officers, because there's an expectation sometimes that the patient or the client will be weaned off of their MAT medicine at a certain point in time. Like 6 months or 12 months or maybe 3 months. But again, it's very relative and dependent upon what is working for that individual person and that patient and what the doctor thinks is working. And so, you have to talk to sometimes you have to advocate to those officials to make sure that they understand it's not always the same case for everybody. And again, the medication here is operates to normalize brain chemistry, block euphoric effects, relieve cravings, and normalize body functions without the negative and euphoric effects of the substance being used. So that's generally, I think, how the MAT medicines are working. We go to the next slide. And then there's also therapy. Therapy, I think, is a huge component of a successful MAT treatment. And so, so MAT is the use of medication in combination with counseling and behavioral therapies. It's that whole patient approach, which I referred to in the first slide a few slides ago. And again, research shows that a combination of medication with therapy can successfully treat these disorders and help individuals sustain recovery. And I'll sort of talk about, it's we're at 2 MAT health center sites and one uses more therapy versus another one that doesn't really have a group therapy component installed within that program. So it is kind of interesting at times to kind of see the difference in that. But generally, a person that's diagnosed from opioid use disorder, again, if they're kind of just starting out, if they're a really active user, they're just now going into MAT treatment. Generally, they start at 1 to 2 visits per week. They get a prescription for about a week's worth of medication, whatever that medication may be. And then they continue to progress, coming in every single week and, having urine screens and meeting with the provider, meeting with behavioral health consultants, et cetera, et cetera. And then as they're doing well and as they're progressing in the recovery, they'll move to 2 visits a week or 2 visits a month. So every other week they'll come in and again, meet with the provider, have urine screens, continue to talk about the recovery with medical professionals. And at the tail end of MAT treatment, an individual, they can come in once a month. So they're getting prescriptions for 30 days worth of medication. But that's the maximum amount a patient can sort of stagger out these appointments. So it starts once a week, maybe twice a week. And then as your recovery progresses, you move and graduate sort of to once a month, if you're a little bit more stable in your recovery. And then eventually, a patient, they may stop treatment altogether. And, if they don't feel that they need the medication anymore, if they feel they're able to, move forward without MAT. But that's, again, a conversation and consultation and a decision made with that individual's MAT provider. And next slide. So one of the sites that Margaret touched on that we're located at it's a long name, Fairmount Primary Care Center at Girard Medical Center. We refer to it as GMC. And GMC is one of 9 sites that are operated by the FQHC of Delaware Valley Community Health. And so this is a smaller site that operates out of a larger drug and alcohol treatment center. They have about just under 10,000 visits a year. They offer it's a PCP clinical site where they offer regular PCP visits, routine physicals, sick visits, HIV care, et cetera, et cetera. But they also have a pretty significant MAT patient population, so where they have about 300 to 400 MAT patients that are coming in at variety of times. Might be, again, those patients might be coming in once every week, once every 2 weeks, once a month. And then at this location, they have MAT providers, behavioral health counseling services. They have a recovery specialist who has lived experience and is able to kind of talk to them more maybe as a peer. Case managers, and then they also have an MLP, us. That's where we kind of come in. So if you go to the next slide. So the clinic at GMC, the MAT clinic at GMC, it operates a little bit, I would say, more informally between the 2 sites that we have. Excuse me. So here there's no group therapy component. Again, there's about 300 to 400 MAT patients, and quite honestly, they're seeing about 20 to 30 MAT patients a day at all hours of, since the clinic opens at 7 and it closes at 4. So, patients are kind of coming in at whatever base, might be, again, once a week or once every 2 weeks. And so they're at different stages or levels of their sobriety or their pathway to recovery. But the day one, they meet with care coordinator. They review and sign the MAT program agreement that they have there at GMC. They start setting up short-term goals. They do a SDOH screener. They use Prepare, which I'm sure many of you are familiar with that screener. It's a nationally used SDOH screener. Then they do an assessment with the provider. They obviously are taking urine to also kind of see what their level of use is, how active they are. They have a conversation with the patient. And then there is an intensive outpatient requirement for this clinic. So they're required to, seek intakes of outpatient programs. And the care coordinators and the staff at GMC are there to help those patients kind of make those connections and make those referrals. And then there's us. Then we also do an intake. Our goal at this particular site, we have two staff, two full-time paralegals. And I should answer, maybe there's a question in the Q&A about whether our staff are full-time, and all 17 or I guess 20-ish of our staff are full-time. Although we do have some no, let me put an asterisk on that. We have 2 AmeriCorps National Health Corps volunteers. So I should say 18 are full-time staff, and then about 2 are National Health Corps AmeriCorps volunteers with us. And so, yeah, so we'll do an intake, but again, with this patient population and 2 paralegals at this site, it can be tricky our goal there is to meet with every single MAT patient, do an intake with them, to see if they have any legal needs that we can help with or address. And if they don't, great. Now you know that we're a resource, we exist. If you have any issue in the future, here's our card, or talk to the doctor, we're here. And that in itself, I think, is really helpful for the patient, just to know that, if they were needed, some legal assistance or advice, or, had some questions or issues that they might need to talk to an attorney or paralegal, we're there to help them. And sometimes they do. Sometimes, lawyers have a bad stigma. And so sometimes when we introduce ourselves, it might take them a day or 2 or maybe a week, and so they can kind of really trust us to contact us to talk to us about their problems that they're having. Or maybe they talk, as Margaret made a point in her presentation, it's also word of mouth. They might go then talk to another patient to see, like, what's up with this attorney over here? Are they legit? Can we talk to them? Can we trust them? So that's at GMC, that's what we're doing there. Again, with the bigger patient population here, it can be tough, and patients kind of come and go. It's a more, I would say, not as many barriers. Again, comparing Esperanza, our next clinic, and this clinic, it's a little bit, I would say, more open for patients to come to. And with that, sometimes the patient aren't as committed to their recovery. And so you have a lot of patients, I would say, at GMC that maybe stop coming to their appointments, kind of are lost to care, as the medical professionals put it. But it's a very open place. Many, patients are always welcome to come back if they lose contact with the clinic, and we'll continue to help them as we go along. Go to the next slide, please. And then Esperanza Health Center, also a federally qualified health center. They have 3 sites in Philadelphia. Again, they offer PCP visits, routine physicals, sick visits, HIV care, MAT care, dental care, pediatrics, OBGYN, kind of, the whole, everything that a federally qualified health center generally offers is being offered at Esperanza Health Center. They also have similar staff at Esperanza, again, MAT providers, behavioral health counseling services, recovery specialists, case managers, and again, us. This Esperanza, this number is it's just under 60,000 patients visits, but that's between all 3 of their sites. And so it just kind of shows, maybe it's not fair to compare that number to the GMC number, but just to give an idea of how, how many visits that this particular site is seeing, or this, I should say, this FQHC is seeing across all 3 of their sites. And then at Esperanza, specifically, they have about 125 MAT patients. And here I would say it's a little bit more of a stricter program than Girard. And I'll get into that a little bit more. But there's also a group therapy component or individual sessions, depending on if the patient is appropriate for group therapy. Some patients maybe have auditory or visual hallucinations, and it may not be appropriate for them to attend a group therapy session. But that's certainly the goal, to try and, have as many people as possible to attend group therapy. And and here it kind of I was mentioning at Girard Medical Center, they have patients coming in at all hours of the clinic between 7 to 3. Here it's a little bit more structured clinic hours for MAT. And so Monday afternoon, we have MAT clinic from 1 to 4, and then it goes Tuesday morning from 9 to 11:30. And then Wednesday afternoon, 1 to 4, Thursday morning, 9 to 11:30, and then also Friday morning from 9 to 11:30. And so, and the patients are coming in, I would say about 10 patients a day. And so it's a little bit more structured where, we're coming into Esperanza Health Center before the clinic starts, whatever day, whatever, if it's a Monday afternoon clinic, the team gets together of, the behavioral health consultants, the recovery specialists, the MLP advocate, the provider, we'll all get together and we'll huddle and talk about the patients that are coming in on that particular day. And talk about the different challenges that we're working on, and sort of all with this, the shared goal of helping this patient along in their recovery. And so, we might be helping with welfare benefits, and then the recovery specialist might be helping getting them a bed in a recovery house, and then, social worker, might be, working with them on other things, and then the primary care providers, talking to them about the actual recovery process and their medication and, how's it going and cravings and those things. And so at Esperanza, it is a little bit more of structured, I would say, as compared to the GMC clinic. And during group, or I should say the MAT clinic hours, they'll have an hour and a half of group therapy. So the patients come in, they'll check in, they'll give urine, and then they'll go straight into group therapy. And then the provider will come in, as they're having group therapy, and pull patients out sort of one by one and talk to them and say, like, okay, this is what your urine showed. How's your recovery going? How are your cravings going? And then if we need to meet with them as well, we'll also try and maybe pull them out of group therapy. However, we are cognizant that, we don't want to interrupt or interfere with too much with their group therapy. However, it's a challenge sometimes because sometimes the patients, if we want to meet with them longer, we'll try and schedule appointments outside of group therapy. But sometimes patients don't want to come outside of group therapy. They're only coming to the Esperanza Health Center site for group therapy, for their MAT treatment. And sometimes this is the only time for us to catch them. And so, it is a balancing act. So, we try our best there to make sure it works. If we go to the next slide. And then again here, just talking about, it's a little bit more of a structure at Esperanza. So we're at Girard Medical Center. There's one intake process. It's just sort of a day one. You meet with the care coordinator and provider, and then you just kind of go from day one. Here, there's kind of 3 intakes where you have an intake A on one day. You meet with the care coordinator, you give a urine, you review and sign the MAT program agreement at Esperanza Health Center. Then you come back on another day. So day 2, you have an intake B. You set some short-term goals. You do the provider assessment. And then on another day, you come back again and you have a longer meeting with a behavioral health counselor. You do an SDOH screener. And then you meet with us to do an MLCP intake. And then technically on day 4, or I guess it would be appointment number 4, is when you would actually start becoming a regular MAT patient at Esperanza Health Center. So I think it's a little bit more rigorous. I don't know if it's intentional or unintentional, but it does seem the patients at Esperanza Health Center, they do seem to be a little bit more stable in their recovery, or not as many patients are lost to care, I would say, at Esperanza Health Center. And then if we go to the next slide. And then this is just a breakdown of all the sort of the case types that we've seen between the 2 sites from last year. I should note that our staffing was a little bit short of last year. So our case numbers are usually higher. But this is gives you, I think, a good example of the types of cases. So for the percentile. So it was really, again, I think it just makes sense naturally. Patients are in recovery, just trying to restabilize their life. So it's a lot of welfare, food stamps, Medicaid, income benefits for Social Security, see if they're eligible for disability, helping them get driver's license, social security cards, birth certificates, utility issues, maybe a little bit of custody stuff. So it's kind of just, I think, just kind of captures a little bit of the case types that we've seen at MAT sites that we have. And then next slide. And then this, again, just just sort of reiterating what I sort of talked about at the beginning, it just makes sense. Again, that the patients here it's recovery is a very difficult process, and a lot of stresses, a lot of barriers, a lot of entanglements. And so we're here to really help them stabilize, help them maximize their benefits, their income, help them, get housing if they have any family issues. And that's all with the goal of decreasing stress, and again, so that they can focus on their recovery. So I think this slide kind of speaks for itself. And then moving along, next slide. And then I just how to be an effective MOP in an MAT setting. The first, it's all, honestly, this is no big secret. I think it's how to be an effective MOP in any setting, really. Integration, so for us, we find having EHR, electronic health record access, as being really important. Margaret talked about that with our partnership at PDPH. It took us 10 years to get EHR access. And we advocated every year of those 10 years to get it, and it happened. And it's making our work a lot more efficient. It's making communications a lot easier without HIPAA concerns. And so we have EHR access at both of our MAT sites, which makes it incredibly helpful and valuable. Attend huddles and meetings, bring donuts. But honestly, add value, be an extension of the health center. And I think that's what we pride ourselves most on, as Margaret talked about again, is that, people trust us. And so they know when they're meeting with us, they know that, we're going to take their stuff seriously and really work with them to help them. And then flexibility, I think Margaret also has touched on that. We're the guests of the health center site. We don't want to make anything more difficult or challenging for the medical providers or the staff. We know that their job is, they have 1,000 things that they're trying to do. So we're working within that existing workflow already, and just being as flexible as possible and accommodating whatever needs that particular health center has. And then again, I think with every MLP, find a health center champion at that health center site. That is not work for your MLP, but someone that believes in an MLP and can kind of vouch for you a little bit. And we've been blessed and lucky enough to really have that across all of our sites, but particularly at the MAT sites, because they also see the value of offering legal services and MLP services within an MAT setting. And then just for MAT specific, these I think are kind of no-brainers. And I'm sure many people already do this or know this, but just come in with no stigma or judgment, honestly. Opioid use disorder does have a stigma. Just come in there with an open heart, no judgment, respect, and that I think is the best approach that you can possibly have with everything. I think generally, but particularly in an MAT setting or a patient who's struggling with active drug addiction, it is it's a disability. It's a diagnosis, it's a medical condition. And we're there to provide offer support and services to help them, in their pathway to recovery and address these medical issues that they have. Relate to the clients. I put be real, these patients, these clients, these folks, they can tell what's happening, what's real, what's not real. They can tell when someone's lying or kind of BSing them or not BSing them. And so I find it sometimes you have to give really bad news or you have to evaluate someone's case and you say, oh, I'm sorry, you're not eligible for SSI. But if you're open and honest and explain things in a truthful manner, and you just are real with them, maybe you're not eligible for SSI now, but maybe in 5 years when you turn 55, you will be, or maybe if you go to some mental health therapy, you will be. And so it's really just that, I think, more about a conversation and just finding that sort of that trust relationship. But I think that's with any, again, attorney-client relationship, is that trust relationship. And then most importantly, follow through. Is, we really pride ourselves on being a resource that when we say we're going to help somebody, we are going to help that person. And even if it's something that we can't directly help with, we're never going to help someone in an immigration case because, we're an LSE funded organization and we might have a restriction, and or immigration cases get very complicated very quickly. And so even if we can't represent them directly, we make sure that they're connected to the appropriate resources so that they can help them. I think that's it. Next slide. Yes. So that's it for me. And then Erin Davison, who we talked about, did this amazing research project for us. And I'm sorry that it took up a lot of time because I think her part is really honestly the most interesting part. So kick it over to Erin.
Thanks, James. Hi, everybody. My name is Erin Davison. I am the founder of Davison Strategic Solutions, and I am a really proud former staff member at PLA. I was thrilled to kind of rejoin PLA temporarily over the course of the last year to do an impact study with them. Next slide. So there are many different ways to communicate impact and results. Historically, the legal aid field has been focused on outputs. So how many cases did we open or close and what kind? These are really valuable, reportable metrics, but there is a larger story to tell about how legal interventions can impact a client socially and emotionally, how they can impact communities, and how this impact can be quantified. For our study, we focus on a few key, really simple questions. What is the impact on clients? What is the impact, if any, on the wider community and the economy? How can we conceptualize this impact? And then what are the greater implications of our results? Next slide. For this study, we chose to do a return on investment study. Return on investment is a really simple performance measure that's used to evaluate the efficiency of an investment. And for our purposes, we were really interested in social return on investment, which links social impacts to financial investments. Social returns can be monetized or non-monetized, and they also can be direct, which means benefiting the funder or tangible benefits that enter the economy, or indirect, which would be costs avoided or those emotional and social dividends that I mentioned. Next slide. Return on investment studies can look different depending on your client population, your organization, and what is most interesting to you. For our study, we did choose to conceptualize the MLCP's impact through the lens of economic insecurity. This is the adverse health outcome that our staff were most concerned with, that the general MLC population and the MAT population brought up in client interviews and in a 2020 needs assessment. And the study's design is founded in the understanding that the relationship between economic insecurity and health harming legal issues is bidirectional. So economic insecurity and instability can create socio-legal issues, and legal issues can create and exacerbate economic instability. Next slide. So there were two sides to the study. The first side is the financial and economic impact side, and then the second side is those social and emotional dividends. For both sides, we use 5 tools. I use 5 years of case data. So that case data is from 2018 to 2023, 5 years of program budgets, 5 years of client survey responses that the MLCP staff take every year, client responses from a 2020 needs assessment, and then also staff survey responses. Next slide. While it would have been very interesting, we did not look at all 3,500 cases that the MLCP opened in the last 5 years. Instead, we specifically looked at cases that were related to our focus on economic insecurity and instability. And we use the iHelp model, which is actually created by Kate Marple, who ran the last webinar, to help us map these cases. So on the first row, you'll see that the legal issues that came up the most in staff interviews, in client interviews, and in the literature are mapped across the 4 domains: income, housing, employment, and personal and family stability. For our purposes, we did exclude legal status. It just wasn't the most relevant to our patient population. And then on the second row, the associated intervention or case type is mapped across the corresponding columns. Next slide. And for each case type, we looked at a few different types of benefits. So to start calculating ROI, if you're interested in doing this yourself or just interested in how other researchers do this, generally, these are the three things you're going to look at: direct benefits, indirect benefits, and the multiplier effect. Direct benefits are tangible financial benefits that enter the economy because of the MLCP's work. So these direct benefits include federal and state benefit payments like SSI. Indirect benefits are then the costs avoided as a result of the MLCP's advocacy. And I examined 4 types of avoided costs that result from PLA's focus on income as a social determinant of health. Those costs are the ones related with homelessness, domestic violence, health insurance and medical debt, and utility payments. I also added a regional spending multiplier. This multiplier is applied to the total sum of federal dollars that flow into Pennsylvania, so those direct benefits. And that includes SSI and SSDI, as well as expenditures from Medicaid and Medicare. This multiplier is meant to quantify the ripple effect of each dollar that's injected into these programs. And by that, I mean that for every dollar that a client spends with their supplemented income, that generates an additional 65 cents in the regional economy. Next slide. The MLCP's results for the financial side of this study were really, really exciting. So the program demonstrated a significant financial impact, generating approximately $41 million between 2018 and 2023, which is a return of about $11 for every $1 invested. Next slide. And then for this social and emotional dividends piece, you can see some of the major themes that emerged in staff and client interviews on the left side of the slide. Stress reduction, which is not surprising to practitioners on this call, was a significant benefit for engaging with the MLCP. Advocates and clients also overwhelmingly identified long-term stability as an outcome, impacting their individual selves, their households, and communities over the intermediate, immediate, and long term. Other major themes that came up were self-advocacy and self-efficacy. And really interestingly to our team is that both clients and advocates spoke of the MLCP as creating a community knowledge base. What they mean by that is that clients armed with more information about their rights and entitlements don't keep that information to themselves, but they bring it to their family members and neighbors, making it so that when someone else has a legal issue, they know what to do or where to go. And then on the right side of the screen, you'll see some patient results that are really compelling, and they also connect to the larger themes on the left side of the screen. So you'll see that patients reported they felt less stressed or anxious and had a greater peace of mind and were able to cope with the challenges of their life. As we're thinking about self-advocacy and self-efficacy, you can see that patients reported they felt like they could be a better advocate for themselves and they better understood their rights. And then 90% of clients reported they would refer a friend or family to the MLCP, with 40% saying that they already had referred at least one person. Next slide. So what does this mean? For clients in recovery from OUD, receiving legal services can translate into better self-advocacy, improved ability to navigate social services, retention with going to primary care and MAT appointments, and a greater likelihood of maintaining long-term recovery. Legal aid helps address housing issues, access to healthcare, and securing necessary public benefits, which, as James explained, are essential for individuals in recovery to maintain a stable and supportive environment. And non-monetary benefits like stress reduction and increased self-efficacy are proven to be valuable to these clients who often face significant emotional and social challenges during recovery. Next slide. And then a bird's eye view perspective on how this research is interesting and can be applied to a larger policy landscape. Legal aid and MLPs don't just provide direct financial benefits to clients, but there is a significant economic multiplier effect, where each dollar invested generates additional economic activity within a neighborhood and a wider regional economy. Legal aid can be seen as a vital economic driver that enhances local resilience, and it can promote sustainable development. The research also demonstrates that legal aid avoids costs associated with homelessness, domestic violence, and access to healthcare. These costs are not just avoided for individual clients and their families, but also for taxpayers and for health systems. And then finally, MLPs are upstream and downstream interventions that have numerous returns. Supporting them and adding an MLP to your health system isn't just a good idea, and it is a good idea, but it's backed by research, and it's almost guaranteed to impact individuals, households, communities, and the wider economy. Thank you, Reha.
That was outstanding. So we're gonna remove the spotlight and transition into Q&A. Erin, thank you so much for presenting, as well as James and Margaret. I know we had some questions that came in via the Q&A, and I believe James answered one of them. Let me pose another one that just came in from Amanda Egert. The question is it possible to get the questions that you use to survey the staff in particular in this report? So I'm going to ask that of the entire team, since I know you all work together on the evaluation process. Erin, Margaret, and James, folks are interested in the survey instrument.
The survey instrument isn't publicly available right now, but it should be by the end of the summer. I can put my email in the chat. You can also give me your email, and I'll make sure that makes its way to you once it's public.
Great. That's great. Had a feeling folks would be interested in some of that as they work on their own impact evaluations and ROI assessment. So thank you so much. Erin's going to share her information in the chat. I know we also have Jay Sicklick, who is one of our faculty members, joining us. And so I want to just continue to encourage people to share your questions in the chat. I want to pose a question to James and Margaret that might be helpful to others who are really new to the space of working with community health centers. James, you started to share on one of your slides some tips, such as, putting stigma aside when working in the space with this patient population. Any tips for folks really at the very beginning stages of medical legal partnership and finding an FQHC or primary care or even behavioral health or mental healthcare services partner in their community?
I'll start, and yeah, if Margaret has anything to add. Well, I would say at first, if you're trying to just identify that your first, partner, just, go to, community meetings, city meetings, kind of figure out like who's out there in the world. There's likely, maybe committee meetings that are, or city council meetings that are addressing, particular topics or areas of interest in your community, and maybe just do a Google search and figure out like what health centers are out there and just start maybe calling around and making connections. It's all, as we all know, sometimes it's all about sort of who you know and making those connections. I'm a friend of so-and-so, or, so just making those connections, I would say. And then just having those opportunities, I think as Margaret alluded to, inner piece is just, whenever there's an opportunity to make a presentation or have a discussion, do that, really make that time and be available as much as possible. I think when we first started, we really we opened the door as wide as possible, and made it, made ourselves available as much as possible. And I think that was really successful. Now we're in sort of the realm of trying to close the door a little bit because we continue to grow and expand so much. So I would say that would just be my tip a little bit, is just be as available and open as possible at the beginning and sort of at the outset. Not sure if Margaret has anything.
Yeah, 100% agree with you, James. I think definitely getting out there in the community. I think we benefited from our former executive director, Anita Santos, and her relationships with healthcare providers in the city, and kind of bringing this partnership about. So yeah, so I definitely sign off on your answer.
Awesome. I have another question for y'all as a team. Oftentimes, I think for legal aid providers around the country, their primary focus is really staffing that attorney position to work on the cases, to get the work done, the legal needs addressed. So two-part question, being able to find, once you do have an MLP, someone to conduct evaluation or the resources is rare. It's not easy, right? So for your team, any tips for either tapping into or finding or securing resources to find an Aaron Davison to conduct an impact evaluation, or making the case that you need an Aaron to conduct such work for your MLP?
I can, I guess, throw in my thoughts about this, but James and Aaron, you may have other ideas. I think definitely we are extremely lucky that we, had worked with Aaron before and already had that relationship. But I do know that many public health programs are looking for preceptors for their students and fieldwork projects. And MLPs, in my opinion, are just an excellent way. There's so many issues going on, so much to study. So I would encourage relationships with public health programs, as well as, other academic programs. There's a lot of research interest. I think that the MLP field has so many possibilities for research. So we've had conversations with other academic programs, and I think those relationships can be really helpful.
Mm-hmm. I know you had a slide on the screen during, I think, your part of the presentation, Margaret, really showing the expansive nature of the medical legal community partnerships that you all run at Philadelphia Legal Assistance. I have another question for your team. Thanks, Margaret, for answering that one. In terms of this particular presentation, we wanted to convey to the audience that doing this work is really about addressing emerging issues so you can go upstream. What are you all hoping to be able to leverage, perhaps as a result of Aaron's findings, using the evaluation or the ROI data to really help advance for this particular population, those who are receiving MAT or need to get into recovery treatment? What are you hoping to be able to do next to move your work further upstream?
I think we now have the data or the proof to sort of back what we've been talking about this whole time, is that MLP works, and MLP and MAT settings, are incredibly successful just based on the nature of that patient population, sort of the needs that they have. And so now that we have, Aaron's amazing research project and the data that comes along with that, we can show that and show the numbers. And I think those numbers are pretty impressive. And people pay attention to that a little bit more, rather than us telling a story. A story is always good, but sometimes it's about the bottom line. And we say we have an 11-to-1 ROI, or we've contributed $46 million to our economy in 4 years. That's significant, and I think that really opens people's ears and eyes and be like, well, what's going on here? And so, and then be able to sort of just take that and sustain funding, I would say, and really just make this a more sustainable project, as not just sort of a short-term thing, but more of a long-term. And let's really put money into this and fund this appropriately, so that we can be as efficient and effective as possible.
Agreed. Margaret?
Yeah, I just wanted to add, I think one of our next stages is really having a conversation with government agencies to show particularly, the return on an investment and what that means for them. You can arrest someone with OUD, and how much is that going to cost the city versus an investment in recovery and legal services that can benefit the person and set them on track to be living a good life. So I think that economic angle is really helpful in driving home the importance of these services.
Mm-hmm. Couldn't agree more. Aaron, anything to add?
I think they summed the majority of it up. I really do think this research speaks to the value not only of legal aid, but the public benefits that our paralegals and attorneys are making sure people have access to. I won't get into that too much, but it's just clear. It drives economic activity, it stabilizes people, and if it's happening in a legal aid MLP setting, you're also saving taxpayers money at the same time.
Indeed. I'm really glad you all mentioned that, because just want to reiterate to the audience that on one of the earlier slides, which we will share, I know folks are asking about how they can also get their hands on the presentation. So in just a couple of days, we will have the recording as well as the slide deck available on the Medical Legal Partnership website. And Reha has plugged a link to the specific page where all of the recordings and archives of this series are being hosted. But you know, the work of the evaluators in the MLP space and the researchers to produce the data, and the teams who are collecting the data, because we know it's not easy to collect that sort of data on the legal side and the healthcare side. They can prove those outcomes that the evaluators and researchers are showing. That's not an easy lift or feat, and so we just want to say kudos to the teams who are doing it, and then also focusing on specific patient populations to get it done. With that, we're getting ready to close out the webinar. Before I do close out, I want to thank James Tidrington, Margaret Robinson, and Aaron Davison for presenting their knowledge and expertise to our audiences as a part of this MLP PIP webinar series. We sincerely thank you for presenting on just one aspect of your work, and look forward to helping people connect with you to learn more about how you got that done, plus everything else you're doing in the city of Philadelphia. And also for the audience, in the slide deck, we also shared a link to Philadelphia Legal Assistance's story that they recently published this year about their 10 years of success running that medical legal community partnership. So take a look at that. Also, we provided a link to an issue brief that the National Center published 2019, I believe, so a few years ago now, on how MLP can play a role in addressing America's opioid crisis and a journey to recovery for all of us. So please take a moment to download those resources and read more about the Philadelphia Legal Assistance Team's medical legal community partnership. Also, again, we're using this webinar series to guide people through the Health Center MLP toolkit, so take a moment to download that as well. And then if you have a really super technical question about the model that the team presented today, which is a Health Center MLP model that they focused on, feel free to reach out to the Bureau of Primary Healthcare using that contact form. So we know some folks have questions that may pertain to funding or project scope as a health center. Feel free to reach out to BIPIC using that contact form. Also, just a plug for next week's webinar. Again, that's the big open forum. Our MLP town halls provide that space where folks can really just talk, share their challenges, their successes, tools, resources. We've invited folks to return if they had presented in the past on this series to come back and join us in case audience members had additional questions. But really, this is a time for the audience to just share with each other and perhaps also show off the amazing work that you've been doing at the Medical Legal Partnership. So again, take the your phones, use the QR code to register, or utilize the link that Reha just shared in the chat. And we hope we can close out the summer of training events with you all joining us. Speaking of the need for tools and resources that pertains to performance measurement and evaluation, just last week, we announced the release of this new issue brief authored by James Tufel, another MLP evaluator and researcher, on fostering sustainability using performance measurement. It covers 8 domains of sustainability with performance measures, all built into the guide. So take a moment to download that, and please spread the word and share it with folks. We believe applicable across primary care settings, especially health centers that are running MLPs. So another thank you to our esteemed panel that really inspired me to immediately invite them to present about their work in Philadelphia to support individuals who are struggling with substance use disorder and opioid use disorder in terms of accessing and maintaining healthy lives in recovery. Again, thank you to the Philadelphia Legal Assistance Team, plus Aaron Davison, for supporting their advancement work with that data. Data is key. Take a moment, folks, to fill out our evaluation survey using the Survey Monkey link in the chat and let us know how well we did today and what in addition you may need to support the planning, implementation, and practice that you are carrying out through your MLPs. Thank you again to our co-faculty, Jay Thicklick and Keegan Warren, for partnering with us on this webinar series, and we hope to see everyone next week on the town hall. Closing out. Have a great day.